Now I get to ask some questions. And now I have to say, as I've said to you both individually, I'm not an expert. I'm a sort of the man in the street. So if these questions are sort of they're not very insightful, then please take them and make something beautiful out of them. First question. How do you see, and let's start with you, Dr. Guerra, how do you see medicine and faith coexisting?
Thank you very much. I think what we can take advantage is of the fact that doctors and nurses are part of us. They just went to medical school and nursing school, and now they are vested with some level of knowledge. But we, as a community, have a spiritual life and a religious life. And so if we can help those people who are now seeing themselves in a professional role that is to manage disease, to transcend to see that they're managing disease in a person, and they use what they would use in themselves to heal themselves in a moment of suffering, spirituality and religious become absolutely meaningful and absolutely obviously useful. Beyond that, I think the target for us are the ones who have, as Andy Warhol said, the 15 minutes of glory. Those doctors and nurses who are now in leading positions. And that is the question for them. Why do you in your personal and family life use spirituality and religious and do not transcend that into the benefit of your students, of your doctors, of your nurses, of the patients and their families attending there? Why are you not moving into building structures of care of the personhood and the spirit? If we are able to take advantage of that, then there is a complete integration. There is a complete integration between medicine and healthcare and spirituality and religion. If we're able to convince those who guide and lead to do what they do for themselves, for their institutions, and for the patients and families.
My three of our children were born in a London hospital called the Chelsea and Westminster Hospital, and it's very new. And when it was built very modern looking, big atrium in the middle. And they got to the end of it and they realized they'd forgotten to build a chapel or multi-faith room or prayer room or anything. And that sort of strikes me as symbolic, really, of where things can go with medicine. We've just sort of forgotten that whole element. The funny side to it, though, is they felt so bad that they used up the entire atrium on the ground floor and built a chapel right at the heart of the church, of the hospital. So I think everything was saved in the end. But can I ask you, Sister Carol, because this is your life. This is what you've given your life to, is this interface between faith and medicine. You see it coexisting?
Oh, definitely. Truthfully, I've been a nurse aide, I've been a nurse, I've been a nursing supervisor, vice president for nursing, and a CEO of hospitals. And I've known thousands and thousands of healthcare providers, from the security guard to the chief of surgery. And we all need God. And we all have, not only at the time of dying, but we all have a great need for the challenges of life. And if you take care of really sick people, and the stress of taking care of really sick people, the horror sometimes of seeing what's been done to really sick people, we have a desperate need for a faith system, a belief system. You just can't face some of the horrors of life and the stresses of knowing you're responsible for this patient. This patient is on a machine and you mess up, or this patient is having surgery and you mess up. And I mean, that's a tremendous burden to people. Or to have to tell people there's not much I can do that will affect a cure in this, or this disease that I've just diagnosed, with what we know right now, is not going to get better. It's going to get pretty ugly. And so it is just so important for people to have a sense of there is something beyond the basics of this drug or this piece of technology, as wonderful as they are. And believe me, I'm a great proponent of progress in medicine. And so you find that, and you often find that people help each other. So often we see, and I can remember in times with me when there were struggling times in healthcare, that people would come to me who were housekeepers, and they would know we had a big issue facing us, and they would say to me, "Oh, sister, if God brings you to it, God will bring you through it. Don't forget that." And you know, we help each other so much, and that's one of the things. You don't need a PhD to be somebody that helps with faith, and people do healthcare better. I know oftentimes in a code situation when they're trying to resuscitate a patient, and the chaplain has come afterwards, the staff need the chaplain as much as the family does. And often they'll say, "I looked up and we were really losing, and I was just so glad you were there praying for us." So I think there's no incompatibility. There may be times when, for different reasons, people balk against faith or pretend not to see any way for it, but or to be too sophisticated for faith. But there's no incompatibility.
Dr. Strand, if I could come to you, that statistic that at any given time, 1/3 of Americans are caregivers is a lot of caregivers in this room, I know. How can you give us some top tips, some advice on how we best support those caregivers as a society?
Yeah, maybe to piggyback a bit off of what others have said, this a big worry I have is if we're going to care for people, as both of our speakers and as many at our table were talking about holistically, if we're going to care for the whole person, then we have to ask people what makes them whole. And I think that is where we often don't ask patients, what gives you strength? What gives you a sense of meaning? What is your understanding of where you are now with your illness, and what are your hopes going forward? And as we were talking about at our table about the concepts of miracles, if people are hoping for a cure or a miracle, the follow-up is, well, what else are you hoping for? And again, what else gives you strength? Because again, we don't want to reduce human beings to a single thing, but I think that makes caregiving harder. The reason I say that is if we in a healthcare system, and again, I'm not blaming, as a physician, I don't want to blame my physician colleagues too much because we are a product of the society in which we work in and a culture that has brought healthcare this way. And there are many good things that have come out of that. But if we are not asking those questions, then all of that responsibility then falls on a caregiver. If a spiritual community is not asking those questions, then it falls back onto the caregiver. So I think that is where the engagement becomes so critical. It's really, there's a really lovely study looking at conversations or family discussions in an intensive care unit. And they sort of were tracking how many times patients asked about spirituality or spiritual discussions and what physicians did. And about 11 or 12, I can't remember the exact percentage, but something about 11 or 12% of the time did any member of the care team actually respond to a patient's comment or question about spirituality in a very vague sense. So we're very bad about this. And part of this is because I think we're all very uncomfortable engaging in the conversation. And it's not also, again, just to bring this back, it's not just the physicians who are uncomfortable. Again, looking at surveys of community clergy are uncomfortable engaging in conversations about end-of-life care with their congregants. So we're all uncomfortable, which I guess is good because then we're all in this together. But if we're all uncomfortable, then where does that leave the caregiver who is wrestling with those questions themselves? So we were talking at our table, one piece I thought was really beautifully brought up was the responses to questions or fears were often met with, well, I'm praying for you for a miracle. Well, they can fight it, right? But what happens when that doesn't happen? What does the caregiver to do when that doesn't happen? They are left feeling potentially more isolated. I was delighted there was a clinical psychologist at our table, and so just to bring something out of clinical psychology, Avery Weissman, who is a psychologist at Harvard, talked about this concept of the middle space of knowing. And Vicki Jackson, who's the chair of palliative care at Mass General Hospital in Boston, has brought this now even more into the palliative care realm, talking about the concept of prognostic awareness. So where do patients understand themselves to be with their illness? And very often this concept is that we swing back and forth between hopes that are more likely to be realized, potentially comfort, potentially being at home with our family, to hopes that maybe are less likely to be realized. Maybe that's cure. And again, that's not always the case, because there are cures, there are things that are miracles that do happen. But people swing back and forth, and what we are very bad at in medicine and in our, I think in many of our faith communities, is the inability to tolerate the back and forth, the swing. We haven't put conversations in place that allow people to express their fears without us immediately trying to jump in and fix it. And so I think that's one thing that we can do to help our caregivers, is to figure out better ways to have these conversations where we can simply be present and minister to them in our presence with them, as opposed to trying to fix their emotions.
This is fascinating. Dr. Brera, can I ask you a question which might come across a bit ignorant? Okay, I apologize. I'm English. So it's and it's really, I think, can we get a global perspective from you? I come from England. We have the NHS. We have socialized healthcare. The majority of people, many people do have private insurance, but most don't. And so there is, it's all one. You know, that when medicine basically says, okay, it's time now for this person to go into hospice, that's not seen as the sort of challenge to normal, quote unquote, normal medicine. We've come to America. I'm very conscious here that it's, I don't want to be rude, but it's big business. There's a lot of money in medicine. So when you have someone who's coming to the end of life, it's in the interest of a hospital to keep treating that person with procedures and medications and not release them into hospice. Is that right? Or is that, am I overstating that?
I think it's a complex situation because there's also big business in hospice. The majority of American hospices are private, and they're major corporations, and there are some community, they are smaller and so on. But hospice has also evolved from the 80s, where it was mostly small confessional organizations, to big companies too. So I think there is probably some element of tension brought by competitive interests, but overwhelming. I think the main challenge we have is related to a much larger level of uncertainty about where the disease is heading now. I started in the 80s, where the cancer prognosis was very firm. And then one could really sit down with the family and talk about the moment in which chemotherapy, that is what we were giving at that time, was more toxic than curative. Yes. And then that arrangement about transition might happen. What happens is the treatments now are a little bit less toxic and significantly more effective. And now then the transition is more of a problem. And I think the problem with transition is that, especially in the United States, but in general in many countries, that transition from acute care to hospice requires moving from one level of care to another. That is what makes it so artificial, and what makes it so hard for patients and families to say, what are you telling me, that I need to leave MD Anderson with all these wonderful people and care I can get here, so I can go to hospice with people I really don't know yet and not get maybe x-rays and blood work and so on. So I think this abrupt transition makes it hard for the patients and families to transition. Some of that is system related, the other is knowledge related, but I would propose that overall, overarching everything, overarching those interests and so on, is the fact that healthcare professionals are continuously focused on diseases more than on persons and families. Because once you bring that person to the picture, I think transition becomes more transparent. And once you bring the family to the picture, transition becomes more transparent. And also, I think that we have dealt with medical schools, with major hospitals, with granting agencies, and with organizations in general that have focused on their business, their disease, or in the case of hospice, last days of life with no blood work, with no antibiotics and so on, rather than looking at the complexity of a person. And I think respecting complexity of suffering is very important. I heard Jacob say very importantly that when we're talking about suffering, we need to be very personalized because the components of suffering can be quite different. He gave us this poignant case of this young mom, and the sources of suffering in her were her sources of suffering that were different from others. We need to bring back healthcare, academia, healthcare businesses, insurance, to respect the complexity of humans. And in that complexity, our spirituality and our religious beliefs are a major component of the complexity. I think if we bring back complexity, we fix the problem.
What would you add to that, Dr. Strand? How much, when a doctor is being trained, how much is this even a discussion?
I think it's very little. I think we learn a lot from our nursing colleagues. I mean, one of the things, so my wife is a neonatal intensive care nurse, and then now as a nurse practitioner. And so I would always introduce myself as an intern, because as an intern in medicine and training, the nurse's job is to break you and to make sure that you don't screw up at all, right? So this is important. So I'd always preface my conversation by saying, don't worry, my wife is a nurse. We're okay. And so that would help. But we learned a lot from our nursing colleagues who are at the bedside, who are caring for the person. They are seeing they are not just dealing with blood work. They are dealing with the patient's most intimate and personal aspects of their life. They are seeing the relationships in a way I don't think we see often as physicians. And I think that, there's that component of it. To the financial piece, I want to bring up one more thing I think is important. So I actually think there is a tremendous opportunity for all of us here to engage in how we redesign healthcare. And part of that is because actually the end of life is very costly for a system. And the way we care for patients is very costly as a system. But when we talk about this, what we hear about is death panels, right? So this still haunts the conversation about even examining how we might care for patients differently at the end of life. Because it is costly and it is not providing patients with better care the way we currently. Now, I think things are changing, because I think there have been some remarkable opportunities in whether they have been in the private sector, in academics, in healthcare systems, in the CHA. I mean, really innovative approaches to caring for people at the end of life that are both patient-centric, first and foremost, and financially beneficial to an institution. But I think that conversation of being comfortable with even mentioning those things together, we have to figure that out in a different way that isn't so reactionary. One thing you mentioned, kind of the transition that Eduardo brought up, is so critical. You do this and then you go to hospice. Is one of the beautiful things about the Affordable Care Act was actually a open access hospice provision where you could, and they had some pilot programs where patients could continue to receive x-rays, blood work, even in some cases chemotherapy and dialysis, while being engaged in a hospice team, until those treatments no longer met their goals. So I think that's important to know, that there are opportunities for us as a society to continue to push for a transformation with how we care people. Maybe I'd love to hear what Sister Carol thinks of this as well, because one piece I'll bring up is that the conversation, though, of we as a society, what we demand of our healthcare needs to change, as opposed to a choice checkbox-based system. Do you want chemotherapy or do you want to go home? Do you want a feeding tube or do you want to be comfortable? Those things do not need to be so dichotomous. Instead, what I would love to see all of us pressure our systems to do is say, tell me who you are and what your life means to you and how you want to move forward, knowing what we know about your medical situation. What is most important to you? And then how do we build a plan of care that meets those needs? That's where we need to move. And then we have to obviously have the infrastructure to be able to supply it. But I'd love to hear what other things.
Well, I think those are all excellent points. I have often anguished with physicians. I don't think the large majority of people in what we might call over-treatment or overzealous or non-beneficial treatment is aimed at making more money, particularly since so many of those patients are Medicare and there's a cap. So there's not the financial incentive. But I would say, I see physicians who, if they transition and start to talk about hospice, it's, I gave up on you, or I couldn't cure you. And that's, their goal, their focus is to cure you, to make you better, to fix this problem. And I also see, quite frankly, having spent years and years and years in a hospital, family members. You don't want to treat mother. You give up too easy. No, we've got to try this. I ran a children's hospital for 10 years, and the thing that haunts me always is a magazine. I don't even want, Life magazine, People magazine, all those magazines. The doctors all told me that my child didn't have a chance, and I pushed them, and now my child lives. And how many children get pushed through all kinds of treatment that's not helpful to them or their families or their siblings, because we've got to try one more thing. We've got to try one more thing. So I think it really is important to continue this effort at educating people, making people comfortable. You are a hero when you put people in a better place. And we find when people finally do get to hospice, it's like, oh, but it's 2 days before they die. I do think that what Dr. Strand talks about a transitional thing that's not so black and white, that you can say, all right, well, we're going to keep on this because maybe it'll shrink that tumor that's pushing against some area in some part of your brain or your body that is making you uncomfortable or causing symptoms that we can manage better if we can shrink the tumor a little bit. We're not curing it, we're just shrinking that mass a little bit. I think that that's fine. And I also think that people have a right, again, going back to what do you want? And if we can't do that, if we can't accomplish that, what other things would you want is really important. And I find most people really willing in the political world and the insurance world to hear what the people in hospice say. I would caution us, because I lived through the death panels. I spent more time than any good Catholic girl should in Congress over the ACA, and I lived through the death panels. I mean, that was treacherous, and so it might save money to do good hospice care. That's not important. If hospice care costs twice as much as ICU care cost, we should still do hospice care because it's what's right for the patient. And when we start to say money, I can tell you, you get people stressed out who, yeah, you don't want to spend any more money on me. All you're doing is trying to railroad me out of here. And we get people in, maybe, I don't want to say extremes, but on the edge of some philosophies, who then start to spread the rumor, hospice care is a euthanasia program, and those kinds of things that we struggle with. And so I would say it does save money if it's done right and well in most instances, but who cares? The important thing is that it is the most effective and important and indicated treatment for that patient at that stage of their healthcare problem.
Thank you. Dr. Barrera, if I could come to you. I mentioned I was chaplain at the Brompton Hospital, and you told me about the Brompton cocktail.
Yes, absolutely. The Brompton cocktail, this movement started really in the UK. So I should be speaking really with Jamie's accent, as you can see. It didn't stick as well, but the reality
Yours is pretty cool, I have to say.
Actually, first effort were Irish nuns operating in London and basically in St. Joseph's, and they were giving their patients morphine syrup, and the patients were having better symptom control at the end of life. What was never known is where were the nuns getting the morphine from? That was one of the big questions. Brompton's Hospital improved that, and they created what is called the Brompton's cocktail that became world famous. And the Brompton's cocktail included morphine or heroin with a touch of alcohol and a little bit of cocaine that would have an arousal system. And the story goes that doctors at Brompton Hospital liked it so much that they decided to share it with their patients. And so there was a tradition of looking for comfort in very difficult times, but that was always in all those places accompanied by a great emphasis on you as a person. It was not just the cocktail, it was not just the syrup, it was you as a person that really mattered a lot. So I think we took both. We took the urgent, but we also took the transition towards the important. It hasn't been adopted. It did not get born in Royal Marsden. It was not born in University College Hospital in London. It was born in St. Joseph's Little Hospice on the side or St. Christopher's, and it was painful to get that to ever be accepted within the UK. And in fact, most of the big UK hospitals today lack an acute palliative care unit. The same as most teaching hospitals in the United States, yet lack an acute palliative care unit. So it has been hard to grow this field and to get hardcore academia, hardcore hospital administrators, hardcore leaders to really learn it. I got to tell you that regrettably, what you need to ask them is, where are you going to die or where will your family die? And that sometimes is what really raises awareness on them. Oh my goodness, I have this incredible facility with so many beds and all this, and I have this incredible organization, but really I do not have even a tiny place where I can focus on person-centered care. So I think there's a tremendous opportunity to improve on what has happened before, but you were asking before some of the questions about globality, and this is a problem. We got a global problem. The US leads at this point medicine in the planet. When people come to see what's new, what's exciting, they come to the leading American institutions. If we make palliative care units and supportive care centers, and we make holistic spiritual care a priority here, we will, no doubt about it, we will change what becomes sexy and fashionable in the rest of the planet.
Just off that, on the question of, again, this may be a very ignorant question, but I would imagine there is a huge question around, and where is it for you? End-of-life medication. You don't want to see someone in pain, but at the same time, you don't want to progress their journey to death with the medication. How do you gauge that? How can you help the layman understand that?
So I think, so there's a short answer and there's a slightly medium answer. I think the short answer is that done well, so when you have effectively trained nurses, physicians, pharmacists who understand and have been trained how to take care of patients at the end of life, medicines at the end of life, like opioids, whether it's morphine, we don't do it with cocaine anymore, but now we just do it with other medicines, it does not hasten death. Okay, I think that's important. We allow patients, we treat the symptoms, and the disease takes its natural course. And we have some interesting studies looking at medicines for cancer pain and other disease states at the end of life that I think can reassure people that we are not going to hasten their journey. The more complicated question, I think, is as a society, we are very transactional, right? So we are transactional. We need a pill to fix this. We need a pill to fix depression, anxiety, pain. Pain has become so much more complicated. So now I have a sizable percentage of my practice in our outpatient palliative care clinic of cancer patients who have comorbid or coexisting substance abuse disorders. They have two terminal illnesses. They have addiction and they have stage 4 cancer. And they say to, one said to me recently, when we were trying to put some safeguards around prescribing of controlled substances, I have stage 4 cancer. I cannot believe you are treating me this way. What is the, I mean, it was a verbal, I mean, I felt awful walking out of that room. And so I think part of that is how do then we bring the conversation back to what does, and I'll just use the analogy because why we're here, this component of hope. So what are patients hoping for? And it requires a system that is then, again, able to look at the patient as a whole. So when they have addiction and a terminal illness, they have two terminal illnesses. And so we are not engineered well to take care of addiction. We are not well engineered as a system to take care of mental health. Our opioid crisis is a beautiful example, and our response to it has been quite lackluster, right? Because it is, we do not have a robust system to treat symptoms of pain and other serious illnesses, as evidenced by the lack of palliative care units, but also as evidenced by the way we treat pain in general. So that's a long diatribe that we won't go down, but I think it is something where, again, gets to the concept of, as a health system, we need to invest in multimodal therapies, which include the biologic, but also the psychosocial and spiritual components of care.
And Sister Carol, if I can come to you, when someone is dying and it's very clear they're dying, my dad passed away 3 years ago, and I'm a church pastor. I should be able to talk about death, but I never once used the D word in the room with him. I just couldn't. I felt completely tongue-tied. And that would be an experience for all of us at some stage. Can you give us some help with that? How do you actually talk to someone who's dying?
Well, I think, first of all, we have to look at relationships that we had pre this condition. And if the person was a stranger to us versus a parent or versus a spouse, it can be really a totally different kind of conversation. And I think the first thing I think we need to do is be patient with ourselves. And it doesn't have to be you. It can be somebody else. You may be the person that can deal with other folks, but not your dad. And it may be that your dad doesn't want to have to tell you how frightened he is, or how sorry he is for the way he lived his life, or whatever. And so maybe it's easier for it to be somebody else. And so I think we shouldn't beat on ourselves, because just as, even if you're a really great physician, you are not the physician for every disease. And just as you're a really great pastor, you're not necessarily the person that reaches, you may be really great with teenagers, but not much with the elderly, or vice versa. And so, or you might be really great at the happy times, but not so good with people who have opioids, because the problem is so personal to you from your family or some other reason. And so I think be patient. If you can't do it comfortably, have comfortable conversations, but find another resource. That would be my advice. Don't force yourself to have an uncomfortable, artificial conversation if you don't need to.
I think I'd like to echo Sister Carol's point. We find many times that some of the most meaningful conversations we can have with the family is when the patient is not present, and sometimes with the patient when the family is not present, because we protect each other frequently, and there's difficulties opening up about many things. And so it's a big burden on a family member to have sometimes some of these conversations. That's where another member of the clinical team can be particularly effective.
Yeah.
And having those what we call split visits, in which somebody stays with the patient and has a conversation while some other member of the team has that conversation with their spouse or someone else, opens up channels of communication where people do not have those tensions of dealing with each other. And the same thing we do sometimes in home visits. Somebody goes into a room with a member of the family, and somebody stays at the bedside with the patient, and that can be a way of expressing. And also, if the person is able to talk and open up and cry and have a good cry of the death of their loved one or of their own death, then they feel better. Now they're prepared to watch TV or play cards or something else. And I have had many, many cases in which the patient told me, Dr. Bruera, I know I am dying, but I would not like my wife to know that I am dying, because I know how bad she would feel if she knows that I know that I'm dying. So please don't tell her that I know that I'm dying, and so on. So families do that because they love each other, they support each other, and do the best for each other. So sometimes our opportunity is on splitting them a little bit before we bring them back together.
And you know, Jamie, one thing I would say is if for instance, you sit with your father and you all laugh uproariously about the dumb things you did as kids and the goofy times you had as
How do you know about those?
I checked. I always check references. And the fun times you had, the vacations, the goofy family weddings and all that kind of stuff. Sometimes just having those good laughs, and all of a sudden, it's kind of an aha moment how good God has been to me, how much my life has meant to me and to my family. And that may be just sort of the opener for the next person who comes in the room to have the next conversation. So, I mean, you actually have played a really important role, even though you didn't use the big D.
So I was hearing this and just reminded me of a patient of mine I took care of early in my training, who had a family who didn't want to talk about it. They didn't want to use the D word, right? They didn't want to talk about it. It was a large family, very involved, wonderful group, and the patient, a crusty old lady who I still remember very fondly for many things she taught me that were not related to medicine. But I sat with her with one of my mentors when we were talking, and she talked about how she had to tell her family that she was dying. And so she said, I think I had to tell them this. And I said, well, how did that go? And she's like, well, it landed like a fart in church. And I thought, well, that's hilarious, because having been in church and heard people pass gas, it is quite amusing. And nobody talks about it. Unless it's the pastor's wife, and then, dear Lord, you are in trouble. So I asked her, being the reflective palliative care person that I am, I said, well, how did that make you feel? What was that like for you? And she's like, so wait, why are you here again? I said, well, my job is to be here, and I was kind of stumbling, and then I kind of came up with something. I said, listen, we're here to be there when you fart and smell it with you. And I think that, and she just started laughing, and I was very proud of myself for that moment. But one of the things that was great about it is that she told that story again to her family. And a lot of what it came down to, she just needed somebody there to be there in the room with them when they were having some hard conversations, and then to be able to make some jokes about it. So, and again, that's one family's coping strategy, but it gets to the concept of how, as a community, do you help others? You can serve different roles but just by being there and being a conduit of information, or being able to support someone who's having a hard time saying the dying word, right? They don't have to say it, I think, as Sister Carol saying, they don't have to say it, but making sure you're supported, even though you may not be verbally acknowledging it, I think is critical. So again, that's the role of all of us in this room as part of social communities, as faith communities, is how do we ensure that we surround people with, even if it's just our presence, as opposed to the concept of trying to fix something.
The elephant in the room. There's another elephant in the room, and that is that you three are clearly spectacular people, and anyone that has you involved in their care is unbelievably blessed or lucky, or how you want to put it. That's not true for every doctor. That's not true for every nurse. That's not true for every, and it can be a bit of a lottery, can't it? And so I suppose at times doctors, I don't think, use chaplains enough. I think they can be seen as the sort of fire extinguisher, break glass in case of emergency, and that's it. But
They said, God, get the chaplain.
Yeah, really. Is that really? You see that a lot?
Yeah.
But you work very closely with your chaplain.
Yes, we do. And I think we think that that's one of the wonderful things of having an interdisciplinary team inside a big institution, a palliative care unit and an outpatient supportive care center, that we can talk with each other. Because sometimes the symptoms don't get any better. The pain is bad, the nausea is bad, the symptoms are awful. And what does happen is that there is a considerable amount of spiritual pain underneath that. And then once that is addressed, the symptoms melt down very dramatically. Other times, there are other components of the suffering experience where the chaplain can bring to the team other aspects that the team had not realized and vice versa. So having an integrated team is very important. Unfortunately, in medicines, there's too much of the parachute system in which you put a consult to someone who comes in and does his or her side, and then, yes, they see their aspect of the elephant. And it doesn't really work that I see only the spiritual, only the physical, only the functional, only the family. I think we need to work in a team that puts the whole elephant together and that we have consistency when we look and consistency when we talk and we express with each other. That really supports the patient and the family. Having parachutists fall from different services and the silos of medical care in personhood care are terrible. Social services depend to one team, chaplaincy to another, doctors on palliative care to another, pain doctor to another, psychiatry to another, and so on. So what you have is solitude showing up to see the patient and family, and we need to break through that in a horizontal way. We would not do that with nephrology. We would not do that with cardiac surgery, because if they did not talk to each other and work with each other, that heart surgery would be a mess. And that cancer treatment, if the radiation therapist, the oncologist, and the surgeon do not hash it out together, come up with a plan and do it, it wouldn't happen. With personhood care, partially because of lack of leadership of our deans and our hospital directors and so on, the care is excessively siloed. We have an enormous opportunity to make sure that those teams come together under umbrellas of common supportive and personhood care, so that by the time we go to see Mr. Smith, we've done our homework. After we see Mr. Smith, we do our homework together and we have a plan of care. That again, in my personal respectful view, needs all of us to respect the complexity of being ill and the complexity of dying. If we respect that, we will get there. It's not hard. The talent is there. We just have to coordinate it. We have the Beckhams, we have the Cristiano Ronaldos, but we need an Alex Ferguson to say, y'all are going to play as one team, and then you're going to score. And sorry, Americans, this is soccer.
It's all soccer references. I'm loving it. That's extra. I once walked into a ward. I walked into this guy's room. I had my clerical collar on. He looked at me and he said, "I'm not that sick, am I?" And that was the downside, was that as chaplain you're sort of slightly seen as the angel of death. I think if you're not around enough, if it's not holistic enough, integrated enough. But actually the role of chaplaincy is huge, as long as there's a profile to it. And churches, charitable organizations, everyone can do this, play the part of having this conversation. But the trouble is, I think it's seen as it's that you're making the most of an opportunity to sort of get another notch in your Bible, that you're abusing someone by talking about spiritual things when they're at a sort of quote unquote weak point in their life. How do we combat that? How do we? Because it's awkward. I often found it awkward talking about God when I knew that that's what they needed to talk about, but it's seen as sort of opportunism almost.
Well, I think that goes back to what's important to you, finding ways just to ask that. And then you may have to be back, you may have to do 3 visits, but allowing people, and they may not be, you're ready to talk to them about God, they're not ready to talk to you, but they need to. you may have to come back 3 times. And how many times do people have to come back and tell you you need to have a colonoscopy before you have that colonoscopy? So, I mean, I think that the point of, what's important and what can we do that will be helpful, asking people before we decide what would be good for them.
I think that's exactly right. Is we have to, again, as a society, demand that these types of care are available. So when we think about, so I'm of course tooting my own horn as a palliative care physician, there's never going to be enough of us, by the way, because there's too many people with needs across the country. So we have to we have to train everyone, and that includes we have to train each other as caregivers with how to do this work. But I think having within systems that we interact with, care systems, demanding that palliative care is part of and an integrated part of the care that we provide when someone is diagnosed with a serious illness. And part of it is because of exactly that point. You starting early is what becomes so critical, because whether it's chaplaincy, whether it's palliative care physicians, whether it's social work, however we integrate, those visits early on lay the groundwork for important decisions down the road, which we can be a close partner in walking with someone. But meeting people in crisis is much more challenging than meeting people early on in the stage of their disease, where we can collaborate closely with outside of those silos and break through those silos. What that takes, though, is it takes all of us advocating for those systems. We just recently completed a clinical trial of early integrated palliative care in certain types of cancer across the country. And when the palliative care leads for that trial were interviewing systems to see if they would be, or clinics to be part of that care, one of the things they found was that some of the oncology practices, because this was going to be done in cancer patients, they actually, their insurers, their payers, and this, I don't mean to bring the insurance and the paying back in this, but just to comment on it, I found it interesting, they would not pay for that oncologist cancer care, they would not pay for the care unless palliative care was part of the team from the beginning of the diagnosis of an incurable cancer. So they had to, those clinics had to go out and hire palliative care clinicians to make sure that they could get those insured contracts to see patients with advanced cancer. And the reason was because, it's better care for patients. It's integrated, it's better care. And so we have to demand those things as a population. We have to demand that if we're going to say we want the best care, that this concept has to be part of it. And it takes that push to do so as we continually evolve our healthcare system. So not to be too grandstandy, but that's where I think all of us have a responsibility to continue to say, if we don't like how we're getting it, we have to say, these are some of the interventions that have worked. We need to get people to communicate better across teams. We need people to be less siloed, and we need the person to remain at the center and acknowledge that the checkbox mentality to healthcare can't work anymore. It doesn't allow for the same type of hope that will sustain people across time, because again, as we've talked about here thus far, hope has to change as we grow and as we age and as we experience serious illness.
So we can make a comment to support very much this wonderful point that is, Jamie was bringing up this incredibly important point of a chaplain going into the room totally unarmed, in a sense, to get into that room and break in. As a doctor, I always can say, I need to listen to your tummy, let me look at your mouth, then I can sit down and talk about how are your spirits, how are you feeling. The nurse has a chance to look at the, infusions and this and so on. The chaplain and the counselor come absolutely unprotected. They show up there and they have to go. So what do? It's important for all those others, the doctor and the nurse, to normalize and to welcome the spiritual life. It's my job to ask you, how are your spirits? Do you go to church? How are you feeling about this? Do you have any spiritual pain? We do measure spiritual pain in 100% of our patients, from 0 to 10. And we try to have them, and that opens. So when I say, you know what? Would it be nice if I bring someone who's an expert here, who knows about this much more than I do? Then if I say that to the patient, when you come, you are welcome. But if nobody said anything and you open the door and go in, there will be that reaction that might happen. So that's why it's so valuable to bring those teams, to incorporate with each other, and to normalize our presence, and to, in a sense, make the value of that time spent with that chaplain part of what I, as their doctor, value and what your nurse feel is the best for you?
It's amazing sitting here. You're all so full of wisdom and you're so eloquent, and I could sit here all day, but we're running out of time. But this is a room filled with amazing people with all kinds of networks and passion and a desire to make a change. If you could, it's impossible to probably say to wrap it up in a nutshell. Do you wrap things up in a nutshell? I don't know. One last sort of call to action to our friends gathered here. Who wants to start?
Sister.
I would just say, everybody has a role, everybody has a gift. This is an important thing for the people of our nation, and use your gift. Figure out where you can help. Mona gave you a lot of good suggestions. Figure out where you can help and go to it.
Maybe my call to action is putting the caregiver, I think, as Mona brought up, to the center of this. That we are all going to die, and so how we die matters, and how we go through that journey matters. It matters not just for the dying, but it matters for our loved ones who are there after we die. I sat with a patient about a year ago whose wife, he had just been diagnosed with incurable pancreatic cancer, and about a week after they found out his wife was pregnant with their first child. And one of the things that, again, there was suffering that was not going to be fixed. And there was a tremendous opportunity to surround those two, that patient, his wife, their unborn child, the rest of their community, with a tremendous amount of support. But what I can tell you is the support is fundamentally less than we give for the treatment of that cancer. There is a war on cancer. There is an NIH budget of hundreds of millions of dollars dedicated to curing cancer. There are very few funded palliative care physician positions. There are only 12 programs in the country that train nurse practitioners in palliative care. There are the vast majority of positions and research done within the palliative care sphere is done through private benefactors. So what it really takes is, if we're going to change the way we care for that individual, that patient and his wife and their community and that child after he's gone, it is about figuring out where our priorities must lie. Now, it's not to say that we shouldn't have a war on cancer, but maybe part of that war on cancer is the war on the devastation that cancer leaves to a family in the biopsychosocial sphere. It is about saying, if we're going to attack cancer, we're going to do it in a way that ministers to all points of that patient's experience. And the only way that gets done is if we're able to train more people. And I don't just mean palliative care specialists, but we're trained physicians, nurses, clergy across the country to be able to engage in this work, and that it's supported. And so for those who are in positions to do that, my call to action is to make this a priority, and in the same way that we make so many other things a priority.
And I can echo only the two wonderful points. And I think the great Martin Luther King defined a little bit of where we are. We have a bit of a segregation between biomedical medicine and medical business and academia and the psychosocial spiritual aspect of the human. And he said, I think it was in his letters from Alabama, I think he said that in a segregated world, the segregator has a false sense of security or superiority, and the segregated have a false sense of inferiority. Those of you who are in this part of the world, my advice would be, do not fear. Do not fear bringing up the personhood and spirituality. If you are in a leading role, do not fear leading your program into developing these programs and investing in them. If you do not have the power, do not fear asking the questions about where the people who are supposed to be serving you are not delivering those. Because that sensation when I read those words, it resonated with me. I lived most of my medical career with a false sense of inferiority, feeling that the big curers, the big Nobel Prizes, the big scientists were out there to do the big things and deserved the big budgets, and I deserved the little things on the side. And at some point I said, well, maybe that's not really true. So my advice would be, do not fear.
Amazing, amazing. Dr. Jacob Strand, Sister Carol Keehan, Dr. Eduardo Barrera, thank you so much for being with us today. Thank you.